Everyone. My name is Massimo Colombo from Milan, Italy, and I hold the privilege of co-chairing this session together with Professor Masao Mata, who actually doesn't need the introduction because he's a well-renowned opinion leader in the field of liver disease and cancer. But just for the youngest attendees, I wish to remind them that Professor Mata is a pillar of the Asian Pacific Association for the Study of the Liver, is Professor Emeritus of the University of Tokyo, has spent his life investigating on liver disease, particularly viral hepatitis and liver cancer. And he is in fact a mentee of Professor Kunio Kuda, who was one of the pioneers in the field of liver cancer, globally speaking. So I'm so pleased to co-chair with him, and he will take the lead of the second half of this session. My task is to introduce the three speakers and to tell you that the session focuses on a burning issue on risk stratification for liver cancer in patients with pharmacologically suppressed Hep B and those who have been cured from Hep C with the arrival, thanks to the arrival of the effective DAA. And the burning issue means that we are struggling to identify the best way to run a cost-effective screening program in these patients that are becoming the vast majority of the target of surveillance programs, at least in the high-income and middle-income regions of the world. So without any further delay, I'm very pleased to introduce Professor Amit Singhal from the University of Dallas, Texas. He's professor of medicine. He's also spent his, let's say, early part of his life in investigating on liver cancer, and is by definition a big expert in the field of screening. So he will tell us about towards new tools for HCC screening. Amit, the floor is yours.
Hello, my name is Amit Singhal. I'd like to start by thanking the organizers for inviting me here to present. As you'll see, we're going to be discussing new tools for HCC screening. Here you can see my disclosures. So first, let's briefly review why we do HCC surveillance. HCC surveillance was best evaluated in a large randomized control trial among patients with chronic hepatitis B, in which it was associated with a significant reduction in HCC-related mortality. We don't have similar randomized control trial data among patients with cirrhosis, although we have several cohort studies that show improved clinical outcomes among those who undergo surveillance. This recent meta-analysis showed consistent associations between HCC surveillance and improved early-stage detection, curative therapy receipt, and most notably, overall survival with a hazard ratio of 0.64. Currently, HCC surveillance is ultrasound-based. This has been the cornerstone of HCC surveillance for many years. This systematic review and meta-analysis gives us a good sense of the accuracy of ultrasound for early-stage detection. You can see that the sensitivity for early-stage HCC ranged anywhere from 21% up to 89%, and the pooled sensitivity across studies was disappointing at only 47%. Now, of course, today we can use this in combination with alpha-fetoprotein. The systematic review and meta-analysis identified approximately 7 studies that looked at the combination of ultrasound plus AFP versus ultrasound alone, and each of those studies suggested a benefit of adding AFP. When you take a look at the pooled sensitivity of ultrasound with versus without AFP for early-stage HCC, the sensitivity was 63%, versus 45%. This was offset by a small decrease in specificity, although the diagnostic odds ratio for the two were significantly higher than ultrasound alone. Further, when you input these data into cost effectiveness analyses, ultrasound with AFP is the most cost-effective strategy today. Now, even though this is the most cost-effective strategy, we clearly need to do better than the sensitivity of 63% for early-stage detection. And given this, there has been a search for either biomarker panels or better imaging studies. Let's start by discussing the emerging biomarker panels. This is a recent study that looked at different biomarker panels to increase diagnostic performance. There were 48 biomarkers that were subjected to multivariate evaluation using lasso regression to identify combinations of using 2 to 4 biomarkers. This was looked at in a study with 308 HCC cases and 740 chronic liver disease controls. Among these biomarkers, AFP and DCP were the most important and formed the cornerstone of all of the highly accurate biomarker combinations. You could then add any one of additional biomarkers, including AFPL3, COMP, IGFBP3, or MMP3. And when you looked at these 3 biomarker combinations, you achieved a sensitivity for early stage HCC detection of 65%, competitive to that of ultrasound and AFP. And when you further added age and sex, you could increase that sensitivity to 70% for early stage HCC. Now, among these different panels, GALID is probably the best evaluated to date. This has been evaluated in large multinational case control studies. This includes gender, age, and then 3 biomarkers, AFP, DCP, and AFPL3. On the left-hand side, we see results from a multinational case control study with nearly 7,000 patients, and the sensitivity of GALID somewhere between 60 to 80% for early stage HCC detection, specificity somewhere between 89% and 96%. This has also been specifically evaluated in patients with non-alcoholic steatohepatitis, case control study with 125 HCCs, 231 chronic liver disease, and this achieved a sensitivity of early stage detection of 72% with a specificity of 95%, highly accurate. Now, of course, this is case control data. We need to evaluate this in cohort studies. And this was recently presented in terms of retrospective cohort study from the HEADS cohort, 7 sites in the United States, nearly 1,600 patients followed for 3,800 person years, over which time 109 developed HCC. When you take a look at the sensitivity of GALID at diagnosis, 55% for early stage detection in this retrospective cohort study. Now, beyond protein biomarkers, there's also been interest in liquid biopsy techniques, including CTCs, ctDNA, extracellular vesicles. These things have probably been best evaluated in terms of treatment selection, response monitoring, although there are data even in terms of looking for early cancer detection. Now, when we take a look at the data for early stage HCC detection, there have been 2 different multi-center phase 2 biomarker studies. On the left-hand side, we see data from Exact Sciences, the MT-HBT panel, achieving a sensitivity of 82% for early stage HCC detection and a specificity of 87% in the study, with a panel that includes 3 methylated DNA markers, as you can see listed on the bottom of the slide, AFP and sex, and this case control data. On the right-hand side, you can see a different methylated DNA marker panel, Helio liver, where you can see also sensitivity of 76% for early stage detection, specificity of 91%. So promising in terms of these case control phase 2 studies, although we do need cohort evaluation prior to routine adoption in clinical practice. Outside of specific liver panels, there has also been interest in multi-cancer detection platforms. So here you can see a multi-cancer detection platform that's been evaluated in 2,800 cancer patients, over 1,200 non-cancer patients. And when you take a look at liver cancer specific, the overall sensitivity and specificity were 52% and 99.5%. However, this appeared strongly stage dependent. So the sensitivity for finding liver cancer at an early stage, stage 1 here, 17%, 40% for stage 2, and only when you go to stage 3, stage 4 do you see promising sensitivities of 77 and 90%. That being said, the number of liver cancers in this study, very small, so we need to see larger studies to understand how these multi-cancer detection platforms will perform for HCC. Now, those are all data for biomarker-based panels. There's also been interest in emerging imaging modalities. Probably the best evaluated is MRI, being evaluated in the PRIUS study. This was a prospective study with 407 Child-Pugh A or B patients followed for 1.5 years, over which time 43 patients developed HCC, 42 at an early or very early stage. You can see here that the sensitivity for and specificity for MRI significantly higher than that of ultrasound. Very good performance. However, We must consider other issues such as MRI capacity and costs if we think about expanding this to entire at-risk populations from a surveillance perspective. So interesting, but I don't think this would be the best strategy from a population health perspective. Now, there has been interest in terms of using abbreviated MRI protocols, selecting certain sequences, thereby decreasing in-scanner time, maybe making this more expandable to larger populations. This has been evaluated in small case control studies with promising accuracy measures, sensitivity somewhere between 80 to 92%, and specificity high at 89% to 96%. So very good data coming from these case control data, although once again, still needing further validation. Pathology correlation data do suggest that abbreviated MRI achieves high accuracy in most subgroups, although not all. Most notably, we see that abbreviated MRI appears to be accurate in patients with obesity, as well as patients with non-viral etiologies. Although this one study did suggest that the accuracy of abbreviated MRI may not be as high in patients with Child-Pugh B or C disease. So patients with mild decompensation, or notably patients on the transplant list, abbreviated MRI may not be the best modality. Now, when we think of all of the data that I talked about, I think it is worth remembering that ultrasound and AFP have been prospectively validated, and these performance characteristics that we have truly reflect how these perform. The other modalities that I said are emerging, including GALID, methylated DNA markers, and abbreviated MRI, have only undergone either phase 2 or phase 3 evaluation in case control studies or retrospective cohort studies. And so the performance may be overestimated. And so we do need prospective validation prior to routine adoption in clinical practice. In summary, HCC surveillance is supported by good data in both patients with chronic hepatitis B as well as those with cirrhosis. Currently, the best population-based strategy is ultrasound and AFP, although we see novel blood and imaging based modalities that are emerging. From a biomarker perspective, we have GALID as a protein-based biomarker, and then we have methylated DNA markers that also have promising data. Both need further validation prior to adoption. And then from an imaging perspective, abbreviated MRI also promising and may be useful in select populations pending further validation. Once again, thank you for inviting me here. Happy to take any questions.
It is well known that the achievement of an SPR to either interferon or DAA regimens is able to reduce, but not to completely abrogate, the risk of liver-related complications, including liver cancer. This data come from a model taking into account several factors, including rates of fibrosis progression, waves of DAA treatment, and, for example, HCV screening policies. And as you can see here, the number of SPR patients is expected to increase over time, and most patients with an SPR have a diagnosis of cirrhosis at baseline before treatment. According to this data, also the number of patients candidates for HCC surveillance is expected to grow over time, as well as the median age of those requiring regular follow-up. And in fact, liver cancer is the most frequent liver-related complication among cirrhotic patients achieving an SPR2, in this case, DAA regimens. The risk of liver cancer is higher than those reported for the other liver-related complications. However, the risk of any liver-related complication is higher in those patients with more advanced liver disease at baseline, as measured in this case by CPT score. And again, we have not to forget that the risk of liver cancer may persist for a long time despite the achievement of an SBR. In this study coming from US, liver cancer has been observed up to 10 years after treatment completion. And again, as you can see here, The risk of liver cancer was higher among those patients with more advanced liver disease at baseline, as measured in this case as through FIB4 values. In fact, taking all this information into consideration, all international recommendations suggest 6 months long life surveillance for those patients with a baseline diagnosis of cirrhosis. Concerning patients with less advanced stages of liver disease, recommendations are not unequivocal. As you can see here, for example, ISLD stands against long life surveillance in F3 patients at baseline. On the contrary, EASL strongly suggests long life surveillance for both F3 and F4 patients independently of other factors. Regarding F0 to F2 patients, EASL suggests regular follow-up in case of comorbidities or alcohol consumption, however, with some caveats related to the lack of definition of comorbidities or, for example, alcohol intake thresholds. However, we have to keep in mind that at the moment, there is no indication to modify these universally accepted surveillance strategies based, for example, on other factors such as time elapsed from treatment completion or improvement in fibrosis biomarkers, for example. Well, is it time to move from this universally accepted surveillance strategy to more individualized surveillance strategies based on HCC risk stratification? In the case, we should not only take into account pre-treatment fibrosis data, but, for example, we should probably take into consideration also other factors, both pre and post treatment. I would remind you that surveillance is considered to be cost-effective in case of HCC incidence higher than 1.5% per year. And as you will know, several studies have tried to address the issue of residual risk of liver cancer among cirrhotic patients successfully treated, in this case with DAA. Studies including cohorts of patients treated with oral antivirals do not exceed 5 years of follow-up. Generally, however, the residual HCC risk per year was not superior to 2.5% per year. In some of the studies, also non-SPR patients have been included. However, the number of failures was generally negligible and did not influence the study's results. And some authors also tried to identify independent predictors of liver cancer over time. And not unexpectedly, most of the factors they found was very similar, were the same we had already identified in those patients with cirrhosis that have been treated with interferon regimens. As you can see here, male gender, for example, advanced age at the time of antiviral treatment, metabolic comorbidity or alcohol intake, for example. However, given the possibility to treat also decompensated patients and following the widespread use of DAA, the role of portal hypertension has become more and more evident. Similar factors have also been identified for those patients with F3 and CACLD at baseline, which, however, are not the main focus of the current presentation. The step forward after identification of independent risk factors for liver cancer is their inclusion in models and algorithms with the ultimate goal of more precise risk stratification. We have reported here data from studies including patients with advanced fibrosis where individualized algorithms are more needed. As you can see here, in these studies, a score has been assigned to each variable previously identified, and the final score was finally able to classify patients into different HCC risk classes, as for example, low risk or intermediate risk or high risk of de novo HCC onset. Well, how this sort of stratification may guide surveillance programs? For example, HCC surveillance could potentially be stopped in those patients at very low risk of liver cancer. On the contrary, those patients at high risk of liver cancer may benefit from enhanced surveillance strategies, or, for example, from the use of second-level imaging techniques. For example, we should rethink about the role of biomarker panels and ultrasound in those patients at low to medium risk of liver cancer. And in my opinion, it's fundamental to rethink about the role of other dynamic factors such as de novo comorbidities or aging, which can influence the risk of liver cancer later during follow-up. Well, in conclusion, I will say that long-life HCC surveillance is mandatory in SVR patients with a baseline diagnosis of cirrhosis. However, at least in Europe, clinical practice guidelines definitively endorse HCC surveillance in F3 and CACLD patients with an SVR, independently of other clinical features. Several factors, of course, may influence the residual risk of liver cancer in SVR patients, and portal hypertension plays a major role. And finally, personalized surveillance strategies based on HCC risk stratification are warranted in order to optimize patients' management and to reduce costs. And I will thank you all for your attention.
Hello. I'm very glad to participate in the 15th Digital Piracy Pathology meeting, and I would like to thank Professor Marcelin and Professor Boulier for this kind invitation. So we're going to discuss the HCC risk stratification in NUC-suppressed HBV patients. These are my disclosures, but I don't have anything to disclose specifically linked to this presentation. So how we can stratify the HCC risk? We may classify our chronic HBV patients into those with high risk who may need closer surveillance, although this is not widely accepted. Cases with the standard, let's say, low or moderate risk who need standard surveillance. And most importantly, we can identify patients with no or usually negligible HCC risk who require no surveillance. How can we define the negligible risk? There is no clear answer to this question, and we usually accept that risk is negligible when HCC surveillance is not recommended, and this is mainly based on decision analysis and cost-effectiveness models and mostly expert opinions. In Europe, at least, it is accepted that we don't put under surveillance cirrhotic patients with an annual HCC risk of below 1.5% and non-cirrhotics with an annual HCC risk of below 0.2%. So regarding the HCC risk and HBV therapy, we can consider several parameters. So let's first start with the type of the drug. Does it matter? And from the early studies, we knew that the HCC risk is higher in untreated patients compared even to patients using lamivudine without rescue therapy in the early days, but the risk was decreasing substantially in patients who were treated with a high genetic barrier entecavir at the beginning. And then subsequent studies showed that at least in patients who started treatment with lamivudine, but were using adefovir therapy as rescue upon breakthroughs, the HCC risk was similar to patients who were starting treatment with entecavir. But in the recent years, we had some provocative publications starting from Korea, suggesting that the HCC risk may be higher in patients treated with entecavir compared to patients treated with tenofovir disoproxil fumarate, although this finding was not confirmed in studies from Europe or even in other East Asian cohorts. So what we can say about the controversy between tenofovir and entecavir, perhaps the superiority of TDF cannot be excluded in East Asia, but there are different reports even from the same country, and it doesn't seem to be any difference in studies from Europe. So what about ALT normalization? We initially had this study from Hong Kong suggesting that patients who normalize ALT within the first 9 to 12 months of NUC treatment, they have lower incidence of hepatic events or lower incidence of HCC compared to patients who maintain elevated ALT by that time. We subsequently confirmed these findings in the PHB cohort, and in fact, what we found is that the benefit comes from the patients who start with cirrhosis before treatment. So mainly cirrhotic patients who normalize ALT by year 1 have lower HCC risk compared to cirrhotic patients who maintain elevated ALT at that time. And in a large study from Korea, there were more interesting findings suggesting that the earlier the ALT normalization, the lower the HCC risk, at least within the first 24 months. So the earlier you normalize the ALT, the lower the HCC risk. What about duration of therapy? In the TDF registrational trial, it was reported that patients who start treatment with cirrhosis, they don't have any case of HCC after 4 years of treatment. This was an interesting observation, of course, too good to be true, but we also observed that the HCC incidence is decreasing in cirrhotic patients over time, although it is remaining low but constant in non-cirrhotic patients over at least the first 10 years of therapy. But in cirrhotic patients, in the right side of the slide, you see that the annual HCC incidence is 3.2% in the first 5 years and goes down to 1.6% after year 5. Similar data were reported from Korean patients. Here, the difference in the cirrhotics was not significant, but it became significant when the cutoff was put at year 7 instead of year 5. What about liver stiffness? We also saw that many patients who start treatment with cirrhosis, if they achieve liver stiffness below 12 kilopascal at year 5, they have lower HCC risk after year 5 compared to patients who start with cirrhosis but maintain liver stiffness at 12 or above kilopascal. Of course, the lowest HCC risk is for patients who start treatment without cirrhosis. HBs antigen loss, we know, and these are data from a systematic review, that patients who clear HBs antigen have lower HCC risk compared to patients who remain HBs antigen positive. And this is true regardless of HBs antigen loss coming after treatment or spontaneously. And it seems that the main factors affecting the risk of HCC after HBs antigen loss is cirrhosis or age above 50 years at HBs antigen loss. So how we can identify the patient subgroups who need or do not need surveillance? And this is based mainly on HCC risk scores, which have been developed over the last almost 10 years now. And these are some scores which initially developed in cohorts of untreated patients. They all come from Asia. They include several parameters, but unfortunately these scores do not seem to offer prediction of HCC risk in Caucasian treated at least patients, and they seem to have variable prediction in several independent untreated and treated Asian cohorts. So subsequently, we have several scores which developed in cohorts of NUC-treated patients. They all again come from Asia, except one score, the PHB score, which we developed from a European cohort. As you see, these are very homogeneous scores. They all include age, all but one include gender, all include one parameter of liver disease severity like stiffness, platelets, or presence of cirrhosis. And it seems that these scores offer similar predictability in all the groups and all the cohorts. So these are data from our cohort, and you see that all the scores predict efficiently well the HCC risk, and most importantly, they have very high negative predictive values for the low risk group, above 99.5% for all scores. So how we can select which score to use? I think the most important characteristic is the negative predictive value of the low risk cutoff, which means how confident we are going to be for the patients for whom we don't recommend surveillance. The simplicity and how easy to use the score in clinical practice is important. Of course, the overall predictability expressed by areas under the ROC curves and the proportion of patients in the low risk group also matter. So these are some independent studies suggesting and showing how the areas under the ROC curves vary among the studies. And as you see here, the CAG HCC, the page B, and the modified page B in all independent studies have some acceptable, I would say, area under the ROC curves above 0.70. But if we see the negative predictive values, and here for 5-year HCC prediction, we want to have negative predictive values of above 99%. Here we see that only page B and modified page B offer such negative predictive values. So this is the page B score, which is recommended now by the Israel HBV and HCC guidelines. It includes practically 3 very simple parameters, age, gender, and platelets. And in fact, you don't even have to remember the score. You need to remember that males above 40s, female above the 70s, patients with platelets below 200 or 100,000 platelets, and older than 40 or 30 years respectively, or just males. These are the patients who have at least moderate HCC risk and needs surveillance. And this score has now been independently in at least 10 Asians and more than 5 Caucasian or mixed cohorts with several thousands of patients. Can we predict accurately the HCC risk after year 5? Yes, we can, and we have developed some scores. The SAGE-B score is very simple. It is based practically on age and liver stiffness above at 5 years. And in fact, again, you don't have even to remember the score. Patients older than 50 years or more than 30 years and liver stiffness at least 12 kilopascals at year 5, they need to remain under surveillance. After this relatively simple score, more complicated scores have been developed. This is an effort from the AMAP study, including more than 17,000. This is an effort to produce a score not just for HBV patients, but in any cause of chronic liver disease. And as you see, it offers good areas under the ROC curves and very high negative predictive values, but still remains a complicated score. And in addition, novel learning models have been developed, and at least in the studies in which these models developed, seems to outperform the risk scores in predicting HCC in patients with chronic viral hepatitis. So in conclusion, the HCC risk stratification should be based on HCC risk score. HCC risk scores for NUC-treated patients have many similarities. Page B is one of the first, simplest, and the most well-validated HCC risk score, the only one included in the guidelines. Other scores may reliably identify additional chronic hepatitis B patients with negligible HCC risk during prolonged NUC therapy, and perhaps in the future, novel machine learning models might be useful if at least incorporated into electronic medical care system. Thank you very much for your attention.
Okay, now we have
yes.
now we have the field to start discussing. And I would like to ask Professor Masao Mata to bring to us his own comment and eventually question. And then we will go through the questions that are coming in from the audience. Masao?
Yes, if is there any question for these 3 wonderful talks? First is for screening, and then risk stratification or assessment of the SVR patients, and then finally the HBV patients. Any question from Jidong about these three speakers? Jidong?
Oh yeah, yes. I have just would like have a small question for Professor Havasoridis about you mentioned the several scores for the screening of HCC in patients with hepatitis B. So my question is, what about the effect of treatment? For example, I think some of the models based on the untreated patient, some on the treated patients. So which do you prefer for patients with long-term antiviral therapy? Which is better fitted that population? Thank you.
Yeah, thank you very much, Professor Jia, for the question. I think that among the diagnosed patients, the majority will be treated. Of course, they do fulfill the indications for treatment, those who have active disease, I mean. But for the other patients, so practically we have inactive carriers and patients who are in the so-called immunotolerant phase. I don't think we have very good scores, and the HCC risk is really very, very low in these cases. So I'm not sure that they will benefit from HCC screening. I don't know any study that has been shown a benefit. These are young patients, the immunotolerant, those with those with inactive carriers are older, of course, but the HCC risk is really very, very low unless they develop a progression of liver disease. So if they are treated, we know the scores. If they remain untreated, I'm not sure who are the best subgroups who need surveillance.
There is I have one question to the Amit Singh now, because are you using what kind of tumor markers in your daily clinical practice actually in your hospitals?
Yeah, so right now, the only biomarker that we're using currently is AFP, and we use that in combination with ultrasound. We remain excited about several other biomarkers that are coming down the pipeline, and we're in the process of actually launching a randomized trial to evaluate GALID and obtain better prospective data to see its performance characteristics. I think if those prospective data validate GALID, then we can see these other biomarkers start to be integrated in the future. But based on current validation, we feel that the only one that's been validated at this point is AFP to be used in combination with ultrasound.
Just like myself and Dr. Colomb being around in this area for maybe 50 years, and then Japanese government is very nice for us to use three markers, AFP, AFPL3, and DCP. So we've been using this for the last maybe 35 years in combination in my clinical practice. So I'm very convinced and very happy to see that GALID is supposing, specificity and sensitivity is so good. So if the economy allows, maybe for the sake of patients, we got to use, of course, imaging techniques along with three markers. That's my 35 years experience in Japan. So I'm very happy to see your talk on these matters. And Analog, do you have any questions from your side? Anna, you come late, but do you have any questions?
Well, I mean, we certainly have a lot of patients at risk of developing HCC as well as people with HCC. And like Amit, we use mainly AFP. We're beginning to be able to order GALID, but it's still not widely done.
How do you assess SVR patients? How long you follow SVR patient? Many of your patients are SVR now.
I can't hear severe patient.
Oh, sorry. How do you actually follow the patient, the virus eradicated SVR patients in your clinic?
Oh, the SVR patients.
Yeah.
Well, I mean, in the past, I used to say I would follow the ones with cirrhosis for 10 years because after that, the risk of HCC would be dramatically declined. But I recently had a patient who developed HCC 15 years after SVR, so I no longer know. whether I should truly follow them forever. This is a problem that I think we need to resolve because some of the patients are fairly young, in their 40s and 50s. If we really need to do HCC surveillance for their life, for the rest of their life, we'll be doing it for 30, 40 years. And so I think we need to know at what stage does the risk decline so much that we can stop.
All right. We have a second part, so we got to get into the controversy. Inactive carriers are a risk of HCC. So maybe Jidong Jiang can get started on these matters. Can you get started on this? Jidong is a professor of medicine at the Beijing Friedrich Hospital, Capital Medical Universities. Everybody knows who he is, and he's focusing on the portal hypertension and liver fibrosis. So, Jidong, could you give a comment or some of the lectures on these matters from your side?
I'm sorry, but I'm afraid we are not allowed to. I'm not allowed to discuss at this session. I will give the brief presentation, then discuss. Thank you.
Okay, so please. Is that?
Dear Professor Colombo, dear Professor Omata, ladies and gentlemen, first of all, I would like to thank Professor Marcelin to invite me for this excellent meeting. It's really a great honor for me to speak on this controversy topic together with Professor Anna Locke. This is my disclosure. It is well known that inactive carrier state of chronic hepatitis B infection is characterized by low HBV DNA and a normal ALT. The nomenclature of this stage is ever-changing. You can see here it was used as inactive surface antigen carriers, inactive HBV infection, inactive chronic hepatitis B, and then lately E antigen negative chronic hepatitis B infection. Compared with other stages, inactive carrier stage is relatively benign in terms of low incidence of cirrhosis and HCC, mainly due to its minimal or no necroinflammation or fibrosis. However, in addition to necroinflammation and fibrosis, which are the major common pathway to the development of HCC, chronic HBV infection could also cause HCC through HBV DNA integration into the genome host. So the dual pathway of chronic hepatitis B infection is very important to understand the patients who are still at risk for HCC development, even though they are in inactive stage. Indeed, from this slide, you can see the degree of HBV DNA integration in E antigen negative stage actually higher than that in E antigen positive stage. This is mainly due to longer duration of chronic infection of HBV in subjects with E antigen negative stage. Now, we can see this slide very nicely showing that as the patient become aging, the HBV DNA and surface antigen and other virological markers diminished. However, at the same time, the integration increased. This kind of HBV DNA integration will cause hepatocyte clone expansion and clone hyperplasia, which is believed to the initial step of the HCC development. So this is a very important drivers for the carcinogenesis in HBV-related HCC. In line with this notion, the evidence from a review study, which is a long-term, very big cohort study, showing that inactive carriers have a higher HCC risk and liver-related death than those without any HBV infection. Here you can see the incidence of HCC is lower in subjects without HBV infection. This is inactive carriers with adjusted hazard ratio of nearly 4.6%. Another smaller clinical study also showing that after follow-up of 146 inactive carriers for about 8 years, 2 patients developed HCC. So, dear chairs, ladies and gentlemen, I would like to summarize. Inactive carriers has a low HBV in a normal LT with no or minimal fibrosis. However, there remains a small but persistent risk for cirrhosis and HCC, mainly due to HBV integration into the genome host. The concept of inactive carrier leads to a false sense of security. Therefore, in an inactive chronic hepatitis B infection is a better term for our understanding of HBV disease physics and in preparation for novel HBV therapies. Thank you for your attention.
Well, first of all, I'd like to thank Professor Maslin for inviting me to participate in this conference. It is a pity that we can't all be in Paris together. I've been asked to talk about the HCC risk in hepatitis B inactive carriers. Now, when we talk about the risk, it's not a matter of whether there is a risk or not a risk, but rather the magnitude of the risk, because every person, including those without liver disease, is at risk of liver cancer. It is important, however, for us to determine whether that person is truly in the inactive carrier phase at presentation and throughout the duration of follow-up, and whether the risk of the HCC is high enough to warrant surveillance, and whether antiviral therapy would be able to mitigate that risk. So when we talk about inactive carriers, we're talking about people who are antigen negative, anti-E positive, with low DNA and normal liver enzymes. Well, how do we define inactive carrier phase? The AASLD guidelines define it as antigen negative, DNA less than 2,000 IU per ml, ALT being normal, that is less than 35 units per liter for men and 25 for women, and absence of cirrhosis. More importantly, it required that the initial determination involve 3 assessments at a minimum over 12 months to confirm persistently low DNA and persistently normal liver enzyme, unless the patient also has been shown to have low quantitative S antigen for less than 1,000 IU per ml. And that these patients should continue to be monitored to see if they persist in that inactive carrier phase. The reason for including the quantitative S is because study of reviewed HBV patients show that a one-time categorization of quantitative surface antigen to be less than 1,000 is just as good as monitoring over 3 occasions in a 18-month period to determine inactive carrier phase and to predict the risk of HCC. Many people would argue that even inactive carriers carry a risk of HCC, and they're higher compared to people without hepatitis B infection. But in the review study, the risk is less than 1% after 13 years, meaning less than 0.08% per year, which is below the threshold for HCC surveillance. Moreover, as I've indicated, the people with low surface antigen level have a 10-fold lower risk than people with high surface antigen level. And study in Korea also showed that in the patients who are inactive carriers, even if they're untreated, the risk of HCC actually remains lower than those with antigen negative chronic hepatitis receiving treatment, suggesting the host immune control of hepatitis B might be more effective than antiviral suppression of HBV replication in preventing liver cancer. So back to our major question. Are HBV inactive carriers at risk of HCC? Yes, but the risk is very low, less than 1% after more than 10-year follow-up if they're truly in the inactive carrier phase at presentation. And that risk is likely going to be lower in those with quantitative surface antigen of less than 1,000, and even lower in those who remain in the inactive carrier phase during long-term follow-up. Thus, the risk of true inactive carriers is too low to justify HCC surveillance, unless there's presence of cirrhosis or family history of liver cancer or other risk factors. A major question, other than HCC surveillance or not, is whether these patients should be put on antiviral therapy and whether antiviral therapy can mitigate that risk. there are a lot of data to show that antiviral therapy in patients with cirrhosis and in patients with e antigen positive or e antigen negative chronic hepatitis can reduce the HCC risk. But there aren't any data comparing HCC risk among inactive carriers who get treated versus not treated. And we cannot extrapolate the data from patients receiving treatment for active disease to that of inactive carriers. And as I've shown you in a Korean data study, that the data comparing untreated inactive carriers and the patients with E-negative chronic hepatitis receiving antiviral therapy actually show that the risk of untreated inactive carriers is lower. Thus, at this point, I would say that the risk is there, the risk is low, too low to justify HCC surveillance, and that there's no evidence that antiviral therapy would mitigate that risk. Thank you for your attention.
All right. Thank you very much for the wonderful presentation. Massimo, do you have any question to two of the speakers? Not much time left. Any question to Jidong or the analog to Jidong? We don't have much time left.
I had a general question. We are still stuck with the biomarkers to predict liver cancer, which are strong enough as a negative predictors rather than positive ones. And I think that the path to reach a satisfactory cost-effective approach using biomarkers instead of the classical ultrasound investigation will take longer than expected, in my personal opinion.
Their response analog, how do you actually follow the patients? Even though very low risks, you still follow?
Yes.
I still follow up the inactive carriers because, as I've indicated, they don't always stay inactive for the rest of their life. So after I establish that they're inactive carriers, I typically only see them once a year. But I usually have them do blood tests every 6 to 12 months so that if it becomes more active, we can then initiate antiviral therapy at that time.
I do the same, yes. How about the Jidong professor?
Yeah, almost the same, but in China, we believe maybe a half year is maximum because, you know, ultrasonography is widely used and usually the doctors spend too little time on each patient. We're really worried about this. We don't want to miss the patient. So we say maybe half a year is still the requirement for even for inactive carrier. Thank you.
Right. The question is whether the government is happy about these things. You know, that depends. Okay. Anyhow, we have a lot of discussion. But Massimo, thank you very much. Seeing you, wonderful. And then time is up almost. So
yeah.
Yes.
Thank you to you. And thank you to everyone. Wonderful.
Yes, thank you, everyone.
Thank you.
Yes.
Thank you.
Right.
Good night.
See you soon.
Good
Bye
night.
bye.